Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. My name is Zach Caseberg, your tutor, coach, and guide along the path to passing the RD exam. My biggest passion is to help RDs and RDs to be, just like you, to know how to pass the CDR exam as effectively as possible. And if that sounds like you, then hey, you're in the right place. Just want to open an intro a little bit to all of you. Just ask if you haven't subscribed to the show yet, please do. It does help out. Listen, review, give it whatever grade you think that I really deserve for the show. I don't mind whatever. And if you want to leave comments of any kind of stuff that you want to see on future episodes, you want to see me talk about or not talk about, you can always let me know. So remember, you can leave that in the RD Exam Ready YouTube page, on Spotify, anywhere, Apple, wherever you like to listen to the show. Go for it and just keep me in consideration for that. If you're looking like me right now, then you might be coming out of the holidays a little bit, and you likely might be holding on to some stress. I know I certainly am. Stress is a funny thing. Not that funny, but it is a funny thing because for people who aren't actually acutely ill, stress is our day to day, right? Our work, our family, our financial strain, and everything in between. But for a patient or someone who is acutely ill, stress represents something like totally different conversation. It's the stress on the body, and it's the inflammation that it causes. Stress in the acutely ill patient is that inflammation that ultimately makes a disease worse and contributes to a lot of the things that we care about as RDs. Mainly, acute systemic inflammation also can lead to a catabolic state and muscle wasting we know is going to follow in periods of catabolism. If that isn't up our alley, I really don't know what is. But here's the hard part. The labs of inflammation can be a bit hard to understand. It's like trying to know how to draw or write, but not quite knowing how to hold a utensil. So today I wanted to talk about these stress or these inflammation labs, aka the acute phase reactants. Here's what kind of happens. In response to injury, local inflammatory cells like our macrophages and neutrophils, they secrete a number of these inflammatory cytokines in the bloodstream. You don't need to know these for the exam, but these things would be like interleukins, like IL-1, IL-6, tumor necrosis factor. And the liver is really important here. It responds by producing many of these acute phase these reactants or these proteins. At the same time, the production of other proteins is reduced. So, whenever we go in periods of inflammation, we get an increase in making some of these proteins and a decrease in making others. When there's an increase in those acute phase proteins, we call those a positive acute phase reactant, meaning they go up. When they decrease in periods of inflammation, we call that a negative acute phase reactant because they go down. Increased acute phase reactant proteins from the liver may also contribute to the promotion of sepsis and other systemic inflammatory conditions. So, yeah, it's a pretty big deal when it comes to the hospitalized patient, right? For acute phases, for the acute proteins are defined as those with a plasma concentration that's going to increase or decrease by about 25% during inflammation or metabolic stress. Again, the positives are going to be the ones that go up, the negative proteins are going to be ones that decrease. We're going to start by talking about the negatives and just one of our positives today. Each of these different labs has a different half life, and I don't need you to know the half life for every single one for exam day, that's not needed. But what we need to know is what a half life is and just understand it a little bit. Half life or shorter half lives, remember, half life is just the amount of time it takes for half of a protein to either be eliminated or broken down by the body. So, proteins that have a short half life are going to be much quicker to respond to inflammation than those that have a longer half life. Meaning, some of these labs that we're looking at, you may say, hey, I'm going to see that change really quickly in inflammation, and some might not change quickly at all. Let's start with our big guy here. Big boy, albumin, or albumin as I call him. Albumin is a protein produced by the liver, and what does it do? It maintains the osmotic pressure in the blood. That means it really helps with water balance, it helps to draw water back into the bloodstream when it's needed, and it has a normal value. That normal value, I say, let's just talk about it now, is about 3.5 to 5.5 grams per deciliter. The way we can go about remembering this is albumin, Al is the first name, Bumin is the last name. They're always bumming around. They're always being a bum. And they're all out here bumming for money and they ask for about 350 to 550 so they can buy themselves a drink. That's about how much it would cost to buy a single thing at the gas station, I would say. So 3.5 to 5.5, that's the normal value we're looking at for albumin. Albumin is a negative acute phase reactant, negative meaning it's going to decrease during periods of inflammation. Albumin will decrease after things like surgery, inflammation, acute illness, and so it's very common to see low levels of albumin in a patient that's hospitalized. This is due to a few things. One, the liver, once we go into inflammation, it stops making as much albumin, so we have a lower synthesis rate where it's just not making as much of it. And we also could see an increase in how albumin is used in the body. So that can cause us to lose some albumin in the blood as well. This is exactly why albumin is not a good measure or indicator of protein status, it's because it's very sensitive to inflammation and hydration status as well. And to boot, albumin has a pretty long half life. So I ask you, RD, to be if it has a longer half life, is it going to be the best indicator of short term stress? Maybe, maybe not. But we could definitely see low albumin with chronic stress and even acute stress too. Now let's talk about prealbumin, okay? Prealbumin, also known as transferrin, is another hepatic protein, meaning it's made from the liver and it's transported in the blood as a complex with retinol binding protein and vitamin A. Let's repeat that one time. Albumin is another protein, but prealbumin is a protein that floats in the blood. It hangs out with its little buddy retinol binding protein who hangs on to vitamin A. And what prealbumin does is it does so much for the body. It transports many minerals, many of our thyroid hormones as well, and it is known to have a very short half life. And because of that, it can be a little better marker of protein status compared to regular albumin. Prealbumin will drop in periods of inflammation and stress, so it is also going to be considered a negative acute phase protein. Let's talk normal levels of prealbumin. Normal levels is going to be about 15 to 30 milligrams per deciliter. So we aren't talking about albumin, who is at the drinking age to buy his drink for 350 to 550. We're talking about pre-albumin, who was about 15 to 30 years old during that phase. AKA 15 to 30 is normal levels of prealbumin in the blood, and if we saw lower levels than that 15, we're probably thinking stress and inflammation in that case, right? Now let's talk retinol binding protein. We just mentioned it a little bit. It has the shortest half life of all the proteins that we discussed today. It's also made in the liver, and it's a very small plasma protein that floats around with its buddy prealbumin, and it binds and transports vitamin A throughout the body. It is also a negative acute phase protein. It's going to fall in the presence of inflammation and stress. It also may not be as sensitive to respond to refeeding as maybe some other protein labs. To help remember the lab values for RBP, it's 3 letters and 7 syllables. So the normal levels are from 3 to 7 milligrams per deciliter. So what I think is RBP, that's 3 letters, there's your 3, and then retinol binding protein, that is 7 syllables, about if I counted that correctly. So you're looking at about 3 to 7 milligrams per deciliter for a normal level of retinol binding protein. Anything lower than that is probably going to be due to some level of inflammation or stress on the body. Now, let's go through transferrin. It's our next protein to discuss. Transferrin transports what? Iron, right? It's the iron transporter in the blood. And it's the fact that it's a protein similar to albumin, as it is also a negative acute phase reactant. The liver makes transferrin just the same way it makes albumin. In periods of inflammation, the liver, just like all these other proteins, is shifting away from making transferrin. It doesn't want to make it as much. It tries to prioritize some of the other proteins instead. So what happens is we get a drop in transferrin during periods of inflammation and stress. And those normal levels for good, healthy adults would be 200 to 400 milligrams per deciliter for normal transferrin, lower levels of that during periods of inflammation. Now let's go through a bit of the positive here. I've only got one major positive one for us to talk about today that I think is exam necessary, and that would be C, reactive protein. It's the main positive acute phase reactant that increases in periods of stress or inflammation. And it is made where? Well, you guessed it, it's in the liver. So in periods without inflammation, your CRP is actually really low. It's like 0 or zero point 0.3 is normal levels of C-reactive protein. But when we're inflamed, we see it go above 1 and even so high as to go above 10. So maybe we'd say high is like 1 to above 10 is about those high levels for CRP. C reactive protein tends to be the highest around 4 to 6 hours after injury or surgery. It begins to diminish after some time. In the text, it was noted that as levels of C reactive protein diminish, our body begins to shift to a more anabolic profile. And that's allowing us to feed the patient and actually get them to build back some of that muscle loss that they might have lost through kind of the catabolic state there. Now, we've just done a brief kind of run through with those. I want to apply them to 3 practice questions for our episode today. So let's dive into our first one here. A female patient's labs are taken prior to routine surgery. Her pre surgery albumin was 5.5 milligrams per deciliter, and after surgery, the albumin decreased to 3.0 milligrams per deciliter. The RD should infer what? All right, so here's the patient's labs. Started at 5.5, she went into surgery, it dropped down to 3. Now let's see what we should infer based on this. A, the patient was malnourished prior to admission. B, the patient consumes a low protein diet. C, the patient should have their C reactive protein drawn. Or D, a decrease in albumin is normal after surgery. Let's use process of elimination to see what our best answer is, starting with A. The patient was malnourished prior to admission. Well, I'd ask you, RD, to be, do you think that we have enough evidence to say the patient was malnourished? Are we just going to use that albumin to mark that? I don't think that's our best marker. We've talked about that. It can be very sensitive to lots of things. I don't think we can infer that they are malnourished. I would get rid of A. B, the patient consumes a low protein diet. Well, similar to A, I don't know how we can infer that. We don't seem to have enough information to say they have a low protein diet. I don't know if the albumin by itself is really going to sell that for me. So I would get rid of B. For C, the patient should have their C reactive protein drawn. Maybe. I'm just going to put a little question mark by that. Or D, a decrease in albumin is normal after surgery. I feel like if I'm stuck between C and D, D is my best answer that albumin will decrease directly after a surgery, inflammation, or stress. It does have a long half life, but it does take a dip a lot of the time. So if I was stuck between C and D, I'm going to go with my best answer, which would be D, that a decrease in albumin is quite normal after surgery, and it would be our best answer for number 1. Number 2. Which of the following are considered negative acute phase proteins? Which of the following are considered negative acute phase proteins? A, retinol binding protein, C reactive protein, and albumin. B, albumin, C reactive protein, and transferrin. C, transferrin, albumin, and prealbumin. D, C reactive protein, white blood cell count, and transferrin. So we need to pick the one that is all negatives, are all going to decrease in periods of stress. Starting with A, albumin, C reactive protein, and transferrin. Which of those does not fit with the others? Well, that would be C reactive protein does not fit with those other ones there, right? Because we know retinol binding protein, C reactive protein, albumin, those 3 will decrease, except C reactive protein, which will increase. So we know A is not the right answer. B, albumin, C reactive protein, transferrin. Well, again, just like A, we know C reactive protein is a positive acute phase reactant. It is not going to decrease in periods of stress. So I'm going to rule out B as well. C, transferrin, albumin, prealbumin. This seems like a great answer. All three of these are considered negative acute phase proteins, and all will decrease in periods of stress or inflammation. D, C reactive protein, white blood cell count, and transferrin. I don't think D is the best answer, especially because C reactive protein is going to be a positive acute phase reactant. So I would say let's get rid of that one, making C as our best answer for negative acute phase proteins. Number three, let's see what you got. A 70-year-old male patient is admitted to the hospital with ascites. He has reported weight gain of 15 pounds, and his labs indicate that he has a low serum albumin in normal liver function tests. The patient consumes 100 grams of protein per day and 1,500 calories. The patient's albumin is low due to what? One more time with that. 70-year-old male patient is admitted to the hospital with ascites. He's reported weight gain of 15 pounds, and his labs indicate he has low serum albumin and normal liver function tests. The patient consumes 100 grams of protein per day and 1,500 calories. The patient's albumin is low due to what? Okay. So, as we're looking at that question, let's just point out a couple things. Patient is admitted to the hospital with ascites. So, what is ascites? That would indicate a large amount of fluid in that abdominal, that peritoneal area that's in there. So, he's retaining fluid. He's reported weight gain of 15 pounds. Okay. That might point towards the fluid. And the labs are indicating low albumin and normal liver. As far as his calories and protein goes, my kind of baseline says 100 grams of protein per day is okay. 1,500 calories could be a little low depending on how big he is, but that could be okay too. Let's just see how we feel. For A, the albumin is low due to A, fluid imbalance, B, inadequate protein intake, C, inadequate kcal intake, or D, liver dysfunction. Starting with A, fluid imbalance. I do feel there is a fluid imbalance going on of some kind since the patient is admitted with ascites. He's had weight gain and he does have a low serum albumin. So the albumin may be low due to the fluid, but I want to see these other answers first. B, inadequate protein intake. 100 grams of protein per day, that doesn't really feel low to me. It doesn't feel inadequate. I mean, if he was like a really large patient, maybe. But again, he's 70 years old. The protein feels okay to me. I can bring it back, but I want to get rid of it for right now. C, inadequate kcal intake. Well, what I wonder is, would inadequate kcal intake be the reason that has the low albumin? Or would low protein intake do that more likely? I don't think C is a good answer either. Kcals just feel okay, maybe on the low end, but I don't think it's enough to really push that albumin down. D, liver dysfunction. I think we can rule this one out too because in the question it said normal liver function tests. So I don't think it's a liver issue, a liver cancer, a hepatitis, anything like that. I think it just is an issue of fluid imbalance. It's because of that I would say for this patient, the reason that his albumin is low is due to the ascites and the weight gain that he entered the hospital with. That's a wrap for today's lesson, students. I hope you watched, you listened, you learned. I hope you enjoyed the show. Remember, passing the exam is a journey. We all need assistance along the way. Do yourself, do me a favor. Hit that subscribe button if you haven't. Tell other studying students, rate, review, help spread the word. Keep an eye out on the RD Exam Ready Instagram page. I'm trying to do some new practice questions every day. So if you want to keep testing yourself, check out your question of the day. And as always, happy studying to you, RD to be.